Welcome to this introduction to intracorporeal suturing. I'm Russell Pruitt, a general surgeon with Northwest Georgia Surgical Specialist in Acworth, Georgia. Intracorporeal suturing is one of the most complex tasks involved in minimally invasive surgery. Though suturing is considered a basic surgical skill, few surgeons have mastered the art of intracorporeal suturing. In this presentation, we will discuss some of the challenges of intracorporeal suturing and provide you with some practical tips regarding trocar setup, suture and needle selection, and ergonomics. The modern era of minimally invasive surgery began in the mid-1980s with the introduction of laparoscopic cholecystectomy, first in Germany and then by Drs. McKernan and Say in the United States. With the rapid development of better instrumentation, more complex procedures were able to be performed laparoscopically. In the early 1990s, complex procedures such as Nissen fundoplication, colectomy, splenectomy, and nephrectomy were performed laparoscopically. By the mid-1990s, even more complex procedures, such as prostatectomy and bariatric surgical procedures, were being done laparoscopically. Despite this early development of laparoscopic techniques for complicated procedures, the percentage of these cases done laparoscopically was still relatively low in the early part of the 21st century. In the year 2000, while 89% of cholecystectomies were done laparoscopically, only 11% of colectomies and 25% of hysterectomies were done laparoscopically. The question then becomes, why did laparoscopic surgery not progress more quickly? I think that the answer to this question lies in our inability to suture laparoscopically. Those procedures that required suturing were more likely to have a low adoption rate. This quote from Dr. Soper and Dr. Hunter, published in 1992, is still applicable today. As surgeons, we are conservative by nature, and introducing a new skill into the operating room requires practice in the lab or non-clinical setting before transferring that skill to the operative environment. If a surgeon can master the art of laparoscopic suturing, confidence increases and laparoscopic skill is developed. In this video, you can see that tying a surgeon's knot does not have to be a 15-minute struggle. Through a defined series of maneuvers, the process is quite simple. This video may look more familiar to you. Though this surgeon is a board-certified experienced laparoscopist, this surgeon does not have a plan for the suturing process. This surgeon is trying to tie a knot without understanding the steps necessary to get from introducing the needle to completing the knot. More often than not, problems with suturing are not related to skill levels, but rather because of a lack of understanding about the fundamentals of laparoscopic suturing. If you have found laparoscopic suturing to be a difficult task, you are in good company, and we hope that this program will help you develop an algorithm to allow you to master the art of intracorporeal suturing. The process of developing the skill of intracorporeal suturing may be difficult, but it is certainly attainable by all surgeons. Like any process, you need to decide what your goal is, take appropriate action to achieve that goal, recognize what's working and where your problems lie, and continue to modify your approach until you achieve your goal. The surgical adage of see one, do one, teach one is not applicable in this complex task. It will take a commitment to repeated practice in order to achieve this goal. Most importantly, you need to pay attention to the details of the technique in order to become proficient. In the words of Vince Lombardi, it's not practice that makes perfect, but perfect practice that makes perfect. The best way to achieve proficiency in intracorporeal suturing is repetition. There are many challenges in laparoscopic surgery that make intracorporeal suturing more complex than open suturing. Among these are loss of depth perception, loss of tactile feedback, the fulcrum effect, and the magnification evident in laparoscopy. These challenges can be overcome. With practice, depth perception can be improved. As you practice the more subtle maneuvers of laparoscopic suturing, you will begin to develop a sense for subtle changes in tension. Tactile feedback will also become more evident. Smooth, fluid movements along with control of small changes in instrument position are the keys to success. Trocar setup cannot always be ideal for every case, but there are a few general rules. Place your working trocars about 20 centimeters from the target, with 10 to 12 centimeters between each port. This will provide the best angle for suturing. In addition, placing a 10-12 mm trocar for the non-dominant hand facilitates needle introduction. Camera placement can be either from the center, between the working trocars, or to the right or left of the trocars. The benefit of placing the camera off to the side is improved ergonomics for the surgeon and assistant. For a right-handed surgeon, the camera is best positioned to the right of the working trocars, and for a left-handed surgeon, the camera is best placed to the left of the working trocars. Suture and needle selection can vary in terms of the type of needle, type of suture, and length of suture. In general, silk is easiest to work with, particularly for training. You may find that 2.0 is easier to work with than 3.0, and suture that is dark in color is easier to see than non-dyed suture. When silk suture is wet, it loses memory and is easier to manipulate. The length of suture will of course depend on your technique and application, but in general, interrupted sutures can be best placed when using suture lengths of about 4 inches, and running sutures can be best done with lengths of 8 to 10 inches. Needle selection is likewise important. Most importantly, don't use pop-off needles. Both SH and CT1 needles can be placed through a 10-12 port. To be successful with advanced laparoscopic procedures, it is important to consider ergonomics in the setup of the operating room. The table height is important in terms of ergonomics. If the table will not adjust low enough, or if the patient is too large to allow a comfortable position, then the use of large platforms to elevate the surgeon and assistant is helpful. When possible, accessory energy device cords, suction tubing, light cords, and insufflator tubing should originate from points other than the primary tower to allow free mobility of the monitor to more comfortable positions. This diagram depicts correct and incorrect alignment. The monitor should be placed in front of the surgeon so that eyes, hands, instruments, operating field, and monitor form a straight line. The optimal distance may vary from surgeon to surgeon depending on size of monitor, magnification, and surgeon preference. The monitor should be comfortable for both surgeon and assistant. Monitor height should be slightly below eye level and tilted perpendicular to the line of sight. Adjust the table height and add platforms as necessary to achieve comfortable positioning of shoulders and elbows. Generally speaking, elbows should be flexed at 90 degrees when grasping instruments. If platforms are used, they should be big enough to accommodate both the surgeon and assistant and provide a stable standing environment. The use of angled laparoscopes is essential to the success of minimally invasive surgical procedures. It will allow better visualization of complex anatomy from one trocar site. The degree of expansion of the visual field is dependent on the degree of angle of the laparoscope. Use of an angled scope will greatly improve visualization in the laparoscopic arena. In this video, we begin with a 0-degree scope looking left and right. The pins demarcate the limits of visualization. You can see that by changing to a 30-degree angled scope, we can see further around the cylinder. By changing to a 45-degree scope, we can see even further around the cylinder. Angled scopes will improve visualization from a single trocar site.